Welcome, colleagues. Let's just jump right in. Today, we're unpacking the really complex psychodynamics behind a diagnosis that, honestly, our standard manuals only partially capture. We're looking at the hysterical and histrionic personality spectrum. And let me tell you, as a senior therapist, mastering this specific material is absolutely vital for your clinical practice. So here's the ultimate clinical puzzle. How do you treat a patient when their true diagnosis isn't even in the DSM-5? Relying purely on overt, surface-level behaviors can lead us severely astray in the consulting room. If we just, check off the boxes of what we see on the surface, we might completely misunderstand the intrapsychic world of the person sitting right across from us, and consequently, we end up prescribing the entirely wrong therapeutic approach. In this explainer, we'll cover 5 key areas: the diagnostic dilemma, distinguishing hysterical versus histrionic presentations, cognitive styles and defenses, psychodynamic origins, and finally, navigating erotic transference. Think of this like an intensive supervision session. Okay, Section 1, the diagnostic dilemma, beyond the DSM-5. To start off, we really have to remember that a superficial cataloging of behavior completely misses the well-integrated, higher-functioning hysterical personality. The atheoretical nature of the DSM-5, well, it's particularly problematic here. It paints with an incredibly broad brush. The criteria it lists for histrionic personality disorder essentially just capture the more primitive pathology. But by doing so, it blurs the lines between histrionic, narcissistic, and borderline patients, and it completely leaves out the traditional, neurotically organized, high-level hysterical patient who, frankly, we see in our practices all the time. Moving to Section 2. Hysterical versus histrionic, making clinical distinctions. This distinction is a real game changer. Separating the neurotically organized patient from the more primitive variant changes literally everything about how we intervene. Take a look at the neurotic or hysterical patient. Their emotionality is restrained and circumscribed. Their seductiveness? It's subtly appealing. They actually have mature triangular object relations, which means they can tolerate separation and navigate those complex Oedipal themes involving 3 people. Now compare that to the primitive or histrionic patient. They present with florid, generalized emotionality. Their seductiveness is often crude, inappropriate, and it actually pushes people away. They operate on primitive, dyadic object relations, just a 2-person dynamic. They cling to you and become completely overwhelmed by the slightest separation. Furthermore, we've got to be incredibly careful not to fall for stereotypes. True hysterical patients aren't always the flamboyant attention seekers society pictures them as. As the psychoanalyst Robert Wallerstein noted, sometimes they are painfully constricted wallflowers, shy and even tongue-tied in interpersonal encounters, at extremes mousy and totally inhibited in demeanor and interaction. If you're just looking for drama, you are going to completely miss the hysterical patient sitting quietly in your waiting room. Section 3. Cognitive styles and defenses. The impressionistic mind. To treat these patients effectively, we've got to understand how their minds literally blur sharp details to avoid strong, painful emotions. We call this the impressionistic mind. It's a global, really diffuse cognitive style. When pressed for facts, these patients will just offer hunches. You might ask a patient how her weekend was, and she'll just beam and say, "Oh, it was just super," with absolutely zero details. There's this famous clinical example of a highly intelligent, successful professional man who, when asked to estimate the U.S. population, just blurted out 5 billion. He wasn't ignorant, not at all. He just deeply resented having to concentrate on sharp analytical details. His cognitive style was actively working to avoid the discomfort of precision. Now, this cognitive style serves a massive defensive purpose. Historically, this was called law-bell indifference, which is a striking lack of concern about their own symptoms. This defense works hand in hand with profound repression and dissociation. It effectively numbs the patient to their own internal distress. So they might say, "I don't know," but what they dynamically mean is, "I must not know." And wow, this dissociation can be severe. Consider a clinical case of a histrionic patient who was found lightly cutting her own breast with a razor blade at 3 in the morning. She was in a completely dissociated state. Under diagnostic hypnosis, she revealed, "I must suffer as my mother suffered." Her mother had literally just undergone breast cancer surgery. This perfectly illustrates the profound, primitive defense of identification acting entirely outside of her conscious awareness. Moving right along to Section 4. Psychodynamic origins. The need to be desired. Crucially, we must uncover where these adaptations actually originated in their developmental timeline because, and this is key, that timeline dictates our entire treatment plan. Here is the developmental split. The more disturbed, primitive, histrionic patient suffers from maternal deprivation at the very early oral stage. They lack basic nurturance, leading them to turn desperately to the father for survival. In their unconscious, they view the father's anatomy as a substitute for maternal nurturance, what we call the breast-penis equation. This means their later promiscuity is actually an endless search for a mother's care. Conversely, the higher-level hysterical patient, they negotiated that early stage fine, but they struggle with later phallic Oedipal rivalries. They feel they lost out to the mother, so they develop a false self-adaptation to become the father's ultimate object of desire, often becoming exactly whatever they think a man wants them to be, totally at the cost of their authentic self. Oh, and let's not forget our male patients. Hysteria is historically and completely wrongly tied only to women. Male patients exhibit these identical dynamics. They might eroticize the absent mother through exaggerated, hypermasculine Don Juan behaviors, systematically seducing women to vanquish rivals and mask their own fears of exclusion. Or, actually in stark contrast, they might adopt passive, effeminate roles, remaining fiercely, unconsciously loyal to their mothers. But the underlying core, it's exactly the same. The deep, desperate need to be the object of desire. And now, Section 5. Navigating erotic transference. The goldmine and the minefield. We have arrived at what is very often the climax of treatment. Managing the intense romantic or sexual feelings that inevitably surface in the consulting room is both a goldmine for insight and a total clinical minefield. We really have to distinguish between regular erotic transference and erotized transference. While our higher-level hysterical patients develop an uncomfortable, gradual, ego-dystonic romantic transference that they know is unrealistic, our more primitive histrionic patients rapidly develop an erotized transference. This is an intense, tenacious, and demanding expectation of sexual gratification where the patient actually blurs internal and external reality. They genuinely believe the therapy can only work if you sleep with them. To really see the difference, listen to Miss L, a neurotically organized, hysterical patient. She told her therapist, "My subconscious wants to hang on to you, but my conscious mind wants to pretend I don't have the feelings." Those words just perfectly capture the agonizing shame, the hesitation, and the deep resistance the neurotic patient feels when these longings start to emerge. She absolutely knows it's inappropriate, but she feels it so deeply. Now contrast that with Miss KK, a patient on the borderline histrionic spectrum, who aggressively told her therapist, "I see our relationship in two ways. Either we sleep together or I make you hate my guts." That is the aggressive eroticized transference. It's actually a massive defense masking deep hostility and a regressive, almost terrifying wish for total maternal merger. It is entirely meant to paralyze the therapist. When faced with this, we must rigorously monitor our own minds. Watch for these dangerous countertransference warning signs. Ask yourself, are you extending sessions beyond their usual length? Are you daydreaming constantly about the patient? Are you self-disclosing details about your personal life? Or maybe harboring a grandiose fantasy that you alone can rescue them from misery? Let me be clear, these are the exact rationalizations that so often precede career-ending bounding violations. So when the room feels dangerously charged, do not panic. And absolutely do not immediately shut the patient down. Fall back on these 4 procedural steps. First, examine your own contributions. Are you, maybe, subtly encouraging this? Second, accept the feelings non-exploitatively. Tell the patient it's safe to discuss this here. Third, assess how this longing functions as a resistance to deeper pain. And fourth, carefully time your interpretations to connect these feelings to their past caregivers and current partners. That is exactly how you safely mine the clinical gold without detonating the minefield. Ultimately, erotic transference is a form of acting out. It's the patient repeating a past trauma or dynamic in action, right in front of you, rather than remembering and actually talking about it. By holding the therapeutic frame securely, by keeping your boundaries rock solid, we help the patient transition from helplessly acting out these deeply entrenched traumas to actually verbalizing their pain. As we wrap up this explainer, I want to leave you with this final, absolutely essential challenge for your own clinical practice. It is so easy to be swept up in the drama or to be flattered by the idealization. But when your patient looks to you for love, are you prepared to give them understanding instead? Think about that before your next session. Thanks for joining me, and I'll see you next time.